Hi everyone, my name's Ria. I'm the Infectious Diseases lead, and I've got Abby here with me. So you may have seen us from our last presentation, which was on STIs, but just to introduce ourselves basically, I'm Ria, I'm one of the F2s, and I'm based in London. And Abby, do you want to introduce yourself?
Yeah, hi, I'm Abby. I'm F1 and I'm based in Lincolnshire.
So today our present, sorry, can you hear me okay?
Yeah, I can hear you.
Okay, sorry. So as I was going to say, we're doing a presentation on malaria. I can see one person has joined. What we'll do is we'll wait for about 5 minutes like last time, just to see if anyone else comes through, and then we'll get started. So we'll just wait 2 more minutes, and then if no one else comes through, we'll get started. If anyone's having difficulties hearing us or seeing our slides or anything like that, please let us know in the chat. When one of us is talking, the other one will be looking to see if there's any messages. Okay, let's get started. So yeah, welcome to our series on malaria this week. So just to give you a quick overview of what we'll be doing, we're going to cover some introduction and definitions. We'll talk through the malaria life cycle, which is key to understanding both how malaria can act and also how treatments can target the malarial parasite. We're going to talk about risk factors that might make someone susceptible to malaria. We'll cover prophylaxis, both medicinal prophylaxis and physical barriers as well. We're going to cover symptoms and signs, investigations, management, and then we'll have some questions at the end. And we will give you some time to ask us any questions if there's something you didn't understand as we went through the slides. The way we'll do things is when we ask you one of the case-based questions, we'll give you some time to answer it. But if you need more time, you can always pause the video. Okay, so let's get started. So, what is malaria? So, as per NICE CKS, it's known as a life threatening illness caused by the infection of red blood cells by Plasmodium parasites. And transmission occurs through a vector, which is the female Anopheles mosquito. There are several types of malaria because there are several types of Plasmodium. So, the majority of cases are Plasmodium falciparum, which can also lead to severe malaria. You might see things like Plasmodium ovale and vivax being mentioned. They're the dormant types, which we'll go on to in a bit more detail later on. And then there are two other types as well, which are less common in the UK presentation of cases, but are still significant to be aware of for your finals.
Okay, so I'm going to talk through about what the lifestyle cycle entails and the different stages. So on the screen, we have a very brief diagram of the typical life cycle of the non-dormant types of malaria. This also applies to the initial phases of infection for vivax and ovale. However, they do have an additional part where they become dormant, which is not on this diagram. So
What
initially, if we start at the top, we start with the mosquito biting. When the mosquito bites, it injects the parasites into the bloodstream of the person it's biting. Those parasites at that point they go on to infect the liver cells. And when they're within the liver cells, they replicate a lot. They form something called a schizont, and then all the parasites turn into the form called a merozoite. Eventually, the liver cell will rupture, and then it will infect the red blood cells with all of the merozoites. Once they then enter the red blood cells, the parasite turns into the form called a trophozoite. This is also known as the ring form, and that's what's often seen in the pictures and diagrams as well. This then replicates a lot within the red blood cell, and the red blood cell will burst, releasing more of these merozoites, and the cycle continues. Instead of forming more merozoites, you can also form gametocytes. These stay within red blood cells, and these are the sex cells of the parasite. So you first form a gametocyte, and then this can either differentiate into the microgametocytes or the macrogametocytes. These are what are ingested by the mosquito. They're ingested inside the red blood cell still. As the mosquito takes the blood meal and it digests it, the red blood cell is digested, and the micro and macrogametocytes are released inside the lining of the stomach of the mosquito. These then are able to fuse together to form the zygote, and then the zygote attaches to the midgut wall of the mosquito as the eukinete. This then grows and replicates within inside the mosquito, and it forms what's called an oocyst. This is filled with lots of these sporozoites, and when the mosquito then takes its next blood meal from a different person, these sporozoites are released and they're ejected back into the bloodstream of the next person. And then if we just go into the next slide, we'll see the headings for all those stages as well. So we have the blood meal, we then have the infection of the liver cells, we have the infection of the red blood cells, we have another blood meal, fertilization, and the transformation and sporogenesis.
What's really useful to know is the the 7 headings that were initially covered up, as they help you to remember each of the aspects in a bit more detail. So if you know that first you have the blood meal, then the liver cells, then the red blood cells, that helps you remember what comes next in terms of what type of cycle the malaria parasite is at that point. Also, what's useful to know is the particular names. So with the blood meal, it then forming into a schizont, and then the merozoites and the trophozoites, knowing where they fall within the life cycle and getting it right is also key for your finals exams. And it's also really useful to know this in the back of your mind when you're thinking about anti-malarials, which we'll come on to in a second, how they act within the malarial cycle. Okay, something a bit more straightforward is risk factors for malaria. So obviously travel to endemic regions. So endemic basically means where malaria is very prevalent. So areas include sub-Saharan Africa, the Indian subcontinent, Southeast Asia, and South America. Vulnerable populations also lead to them being more likely to contract malaria if exposed to the right conditions. So young children, older age adults, traditionally over 65 years of age, pregnant individuals, and also what's quite key is individuals without a spleen can also be at risk of contracting malaria. Naturally, when you take a history, you might ask them what prophylaxis they've used. If they've traveled to an endemic region without prophylaxis, it should definitely be something to consider. And in terms of the risk factors, it's really important that you cover this within the travel history part of your history taking to make sure that you cover all aspects. I do note that it's hard to see the last risk factors because our faces are covering it up. So I'll just adjust the slides. Is that better for everyone? I think that might be best. We'll keep it this way. So yes, here are the risk factors. Make sure you take good travel histories to make note of where they've traveled to, whether they took prophylaxis beforehand, what sort of activities they did as well. And yes, like I said, young children, pregnant individuals, older adults, and individuals without a spleen or otherwise immunocompromised. Okay.
So we're going to talk first about prophylaxis. So this is not the same as treating malaria, and it's only for preventing getting it. The exact type you want that is taken and is recommended is dependent on the location that's being traveling to, the type of malaria endemic to the region. And in the UK, the only licensed methods of prophylaxis are targeting the red blood cell stage. None of the vaccines that are in the media a lot are licensed yet, and there's equivocal as to whether or not they're going to offer significant protection. So the first thing to think about with malaria is the physical protective measures. This is stuff like using bed nets and clothing to cover all areas which are exposed, avoiding going out during at dusk, because that's when mosquitoes are most active, and the use of strong insect repellent. In malaria, there are lots of regions which have different resistance patterns. So it's important, this is why it's important to take into consideration where you're traveling to, because you need to think about what the resistance patterns are. So typically chloroquine sensitive areas, which is not many places where falciparum is, you can use chloroquine. It started 1 week before entering the endemic area, continued throughout the time in the area, and then for 4 weeks after leaving the area. Alternatively, mefloquine can also be used, which can start 2 to 3 weeks before you enter the area, and then you continue until 4 weeks after leaving the area. There are some more risks of side effects with that. What is most commonly used is doxycycline, and yes, this is an antibiotic. However, it does work on the red blood cell stages and preventing the infection from spreading more and more. So this is started 1 to 2 days before you enter the area, and it's continued until 4 weeks after leaving the area as well.
Just moving the slides. Oh. Is that okay? Can everyone see that? Yeah. Okay. So side effects. Different prophylactic treatments are known to have different side effects. And it's really important to know the risk factors that your patient has in their past medical history before you prescribe prophylaxis. So we'll start with perhaps the more easier ones to remember. Doxycycline, as you may remember from OBS and gynae revision, is contraindicated in pregnancy and breastfeeding. So please do not give this to pregnant individuals. And as you may know from other revision, it's known to cause things like photosensitivity. Another important drug to be aware of, which cannot be given in all cases, is mefloquine. So mefloquine is known to cause neuropsychiatric disturbance, night terrors, and dizziness. It's taken on a weekly basis, but it's contraindicated in epilepsy. Another drug that's contraindicated in epilepsy is chloroquine, and that's known to cause headaches. And then progranil-based treatments are known to cause GI upset. So the full details of the contraindications for each medicine will be in the BNF, so you can always refer to this in practice. But for your exams, it's good to know kind of the main contraindications for each chemoprophylaxis. Okay.
So when looking at the signs and symptoms of malaria, the symptoms, you quite often get these cyclical patterns of features, and the exact cycle pattern and the length of that pattern is dependent on the type of malaria that there is. Some are more 24-hour based and others are more 48-hour based. That is something typically that is presented in exams. However, in real life, it very rarely happens. So your incubation period can be anything from 7 days up to 30 days. There's often a prodrome of myalgia and headache. This is often during the liver stages. And then you get these periodic episodes of fever. People can get nausea and vomiting, abdominal pain, diarrhea. And then If the malaria becomes complicated, then you can get other sequelae, and that's something like cerebral malaria, which we'll talk about in a bit. I mean, you can also get some respiratory symptoms, and that seems to only be with falciparum. Some of the other signs that you can get hepatomegaly, and that's because of the liver sequestration of the parasites in the dormant ones. So that's your Vivali and your Ovali and Vivax. And then you can get neurological signs such as seizures with cerebral malaria. You get anemia and hemolysis, which can cause jaundice as well in some patients when it's very severe. You can get splenomegaly because the spleen is trying to clear out all of the ruptured red blood cells and parasites from the blood. And then you can also get renal dysfunction if it's very severe when you have a high parasite load, because you can get clots and impacting how the renal functions working in terms of unable to filter blood effectively. Some other sort of complications you can get is something called black water fever as well as with falciparum.
Yep. So just to touch a bit more on black water fever, what it basically is, it's a complication of malarial infection where your red blood cells burst in the bloodstream, so that's hemolysis, and hemoglobin is released into the blood vessels and into the urine, and that can lead to kidney failure. So that's black water fever, and you tend to see that in falciparum. And then the other complication is hyperreactive malarial splenomegaly, which I've put in small font there. The reason is it's because it's not frequently asked about, but it's just something you can keep in the back of your mind. What it basically is when you have repeated attacks of malarial infection over a long period of time. So areas where you might see this is the Indian subcontinent, Africa. And when you have repeated attacks of malarial infection, then your spleen basically can get immunologically overstimulated, and that means it can react and become hyperreactive, and you can have quite a large spleen as a result. So again, this may not be something that comes up in your exam, but it's just a cool complication to know in the back of your mind in case you're ever encountering malaria in a clinical setting. Okay, fine. So moving on to investigations for malaria. So blood films remain the gold standard. There are two types of blood films which you can use to investigate malaria, and they're often done as a combination. So your thick blood films are more sensitive to help you detect the fact that there's a malarial parasite, whereas the thin blood films help you to determine the species. So you'll see different signs when you're investigating the blood film. So traditionally, you might see this in a multiple choice question. Falciparum is traditionally a crescent shape. That's the stereotypical question that you might see if they ask you what shape falciparum is. And with Vivax and Ovalia, you can have a finding called Schaffner dots, which I can talk about later in one of the case studies. As per NICKS, if the first blood films are negative, you have to arrange testing 12 to 24 hours later, and again after a further 24 hours to rule out infection. In pregnancy, thick films can be negative, despite the presence of parasites in the placenta, and expert advice should always be sought if malaria is suspected in a pregnant patient. Other investigation findings you might notice in cases of malaria, reticulocytosis, normal white cell count, anormocytic normochromic anemia, and thrombocythemia is also considered characteristics. But the gold standard will remain as the blood films.
So in terms of treating malaria, similarly to prophylaxis, it depends on the type of malaria that you're suspecting, which you can get both from the diagnostics and from where the patients travel to as to what's most prevalent. So falciparum malaria is by far the most common encountered in the UK practice, and the treatment is based on whether or not you have these signs of severe parasitemia or not. So if the patient is presenting with just the fevers, no other neurological complications, no renal complications, and no renal dysfunction, then you go for what's called artemisinin-based combination therapies first line. However, if there's a more severe or complicated malaria, i.e. they presented with seizures, or the parasitemia on the thin film is calculated at more than 2%, then you can have the IV artesunate is preferred. And if it's not possible, then you can use IV quinine. In cases where the parasitemia is greater than 10%, you'd want to be doing an exchange transfusion to clear the blood of the parasites very quickly. In the non-falciparum malaria, you have the option of using chloroquine if it's sensitive, As I mentioned previously, it depends on where the patient has travelled from as to whether or not you think that's likely. So in the chloroquine sensitive groups, you can use chloroquine, or you can also use artemisinin combination therapies. So if you're unsure about the type of malaria, ACT is the way to go. If they're chloroquine resistant, then you need to be using ACT. For the forms of malaria which have the dormant stage, which lives in the hepatocytes, you have Avali and Vivax. For this, you need to give primaquine after you've given the acute treatment to get rid of the parasites remaining dormant inside the hepatocytes. One of the things to notice about this is that in primaquine, you cannot give this in pregnancy. And if you're having a pregnant patient that has presented with non-falciparum malaria, you do have to wait until after they deliver the child to give the primaquine to clear the liver stages.
Okay. All right. So this is what I mentioned at the start of the presentation when I said I'd talk a bit more about how the treatments impact the malarial life cycle. Again, this is more just for wider knowledge, but I think it's useful to know when you're thinking about how do antimalarials or prophylactic treatments work. So primaquine is effective against mature gametocytes and can reduce the levels of it. And then for the erythrocytic form, so that's when the parasite is in the red blood cell itself, things like artemisinin target that area. So you will find that most of the antimalarial drugs tend to be against the erythrocytic form.
So as was briefly touched on earlier, we're going to go into more detail now about the side effects and contraindications to each of the treatments. So with your artemisinin combination therapies, the main contraindications are being in the first trimester of pregnancy or if you have prolonged QT syndrome. The side effects as a result is you can also get QT prolongation, which would increase your risk of getting other cardiac arrhythmias and movement disorders. With artesunate, it can cause a worsening of the hemolysis, so it's something to monitor patients on. However, there are no strict contraindications. Chloroquine, there's a risk of retinopathy with prolonged use, and it's contraindicated in those who have severe hepatic and renal impairment and needs to be used with a lot of caution. It can also cause acute porphyria. Quinine, this also can cause QT prolongation, so you'd want to avoid it in patients that do already have long QT syndrome. And it can increase your risk of arrhythmia, and it can cause an exacerbation of myasthenia gravis too. As a result of that, the contraindications are having myasthenia gravis, optic neuritis, tinnitus, and hemoglobinuria. Primaquine, this is contraindicated in pregnancy, breastfeeding, and granulocy. And then you also need to make sure you screen patients for G6PD deficiency before you give them primaquine, because the patients with G6PD deficiency are prone to having more severe hemolysis as a result of primaquine being given, and this can cause them to go into renal failure, for example. Typically, the side effects you will see with this, you get hemolytic anemia in patients which are G6PD deficient. You can also get methemoglobinemia in people who have NADH, methylglutamate reductase deficiency. So basically, a primaquine, if you've got anyone who's got a metabolic disorder, you want to be checking whether or not it's safe to give it to them first. But the main one is G6PD, which comes up in exams. And then mefloquine, as we mentioned previously, this can cause neuropsychiatric reactions. So if someone has had any sort of psychiatric illness before or convulsions, then you'd want to avoid using this in them if you can.
Okay, so we'll go on to the questions now. So as I mentioned at the start of this presentation, for those of you who weren't there, how we'll run this is I'll read out the question, I'll give you a few minutes to think about it, write down your answer, and then we'll move on to the answer that we've written down. If you need more time, please feel free to just pause the live stream and take your time with things. Okay, so question 1. 25-year-old male returned from a 7-day holiday to Somalia. He went to visit extended family, on and off fevers, nausea, vomiting, and fatigue, up to date with vaccinations, but didn't take any malarial prophylaxis. He has been described as drowsy by his family, and during examination, you find that he has a reduced level of consciousness, so reduced GCS. So what we're asking you is to just have a think about how would you initially investigate this gentleman and what your management would be in a case like this. So what we'll do is we'll give 2 minutes, so until 1927, and then we'll resume and show you the answers. Okay, so let's show our answers. Right, so investigations, you can divide it into bedsides, bloods, imaging, further investigations. So at the bedside, you'd want a set of OBS, especially if they've got a low GCS. You'd want to formally record what their GCS is. In terms of bloods, you'd want to do things like full blood count, renal function, LFTs. What you would definitely like to do is stick within blood films. Some in the clinical world, some hospitals may just add this on if they know it's from malaria or suspected case of malaria, but sometimes you might have to request it. So let's say in this case the smear showed, the film showed Plasmodium falciparum. What would the management be? Well, the drop in GCS possibly indicates severe malaria because it's showing signs of cerebral features. So the treatment would be intravenous artesunate. If that's not immediately available, you can give quinine. For cases like this where you have severe or complex falciparum infections, monitoring in intensive care should be considered alongside supportive measures.
Yeah,
Abby,
it'd probably be worth to add to that. You're not going to get the results from your blood smear of the thick and thin film straight away. So you'd want to start treatment as soon as you're suspecting malaria, as you can always stop it if it's not, but you don't want to miss starting treatment, particularly in someone who's already showing severe signs.
yeah.
Okay, so question 2. We have a 32-year-old female with epilepsy presenting to your GP practice asking for malarial prophylaxis as she wishes to travel to South Asia in a month. Which chemoprophylaxis can she not be offered and why?
So once
Again, we'll give you
again,
some minutes.
yeah, what we'll do is we'll give you some minutes and then resume. Okay.
So if you have a look at what the answer is. So in this case, you want to be avoiding mefloquine, as this is the one that increases the risk of seizures. You also should probably avoid chloroquine because of the neuropsychiatric disturbances and increased risk of seizures. Also, just due to the widespread level of resistance, it's generally tried to avoid using it first line because you don't know for definite that she's going to an area where there is chloroquine sensitive malaria.
All right, so as the questions progress, we're going to make it slightly harder. So I don't know if you guys can see the screen okay? Yeah? Or is it obscured by our faces or anything like that? No. Okay. So the case study is written there at the top. The questions that we're going to ask you is, firstly, what's the pathophysiology of P. ovale infection that makes it different from falciparum, and what's the recommended treatment and mechanism of action? So once again, we'll give you about 2 minutes, and then I'll show the answers. Okay, so we'll go through the answers now. Remember, if you need more time, you can always pause. All right, so you may remember this from medical school lectures, but Vivax and Ovale have something called the dormant stage or the hypnozoite. Basically, the hypnozoite can remain dormant for months in the liver. This means that malaria can reoccur if these parasites are the cause. So primaquine tends to be the treating agent. The reason why is because it causes oxidative stress in the hypnozoites, leading to their death. So just remember, as Abby said prior, it's not suitable for those with G6PD deficiency. So while it might be a great treatment for the hypnozoites, it might not be suitable for those with that deficiency. And then it would be worth having a look at the guidelines to see what other alternative treatment is there, or speaking with a specialist.
So the fourth question, a slightly shorter question, is which chemoprophylaxis options are suitable for pregnant women? So which of the following 5, doxycycline, chloroquine, proguanil, mefloquine, and primaquine, which of those 5 are acceptable? And there could be more than one. So if we want to have a look at the answers. So you can give chloroquine, proguanil, and mefloquine. However, just to be aware of is if you're giving proguanil, you want to prescribe 5 milligrams of folic acid as well. And as mentioned previously, mefloquine should be used in caution in the first trimester. So looking at that, probably the most optimal option is chloroquine. However, you do need to consider whether or not the patient is traveling somewhere where there is resistance, as that if there is, then it wouldn't be the best option.
Right, so now we're going to get into some slightly more niche or harder questions for falciparum. So on a peripheral blood smear, the characteristic appearance of, I think that's supposed to say gametocytes, I apologize for the typo, gametocytes for falciparum is question number 1. And question number 2, what is the complication of falciparum characterized by massive intravascular hemolysis and hemoglobinuria? So we'll give you 2 minutes. Actually, let's do 1 minute for this one, and then we'll show the answers. Okay, let's go through the answers. So as I've mentioned in my earlier slides, crescent or banana shaped for falciparum gametocytes, and then black water fever. Because if you remember what I mentioned earlier, with black water fever, what happens is your red blood cells rupture, hemolysis in the blood vessels. It then ends up in your urine and can cause kidney damage. Okay, just to summarize our references, so we got the life cycle image from Geeky Medics, and we used a combination of Nair CKS and other resources as well. Now's the opportunity to ask us any questions if you have any, so feel free to put them in the chat and we'll answer them one by one. Otherwise, we'll wait for 5 minutes and end the session if there's no questions. We'll give it 1 more minute. In the meantime, if there's a QR code on the top left of the screen, if you want to just scan that and give some feedback, if there's any way we can improve our sessions, if there's any other knowledge you wanted to know but we didn't cover, if there's anything you didn't understand, just let us know using the QR code. And we'll give it 1 more minute for any questions in the live chat, and then we'll leave it. Okay. Um, I can't see any more questions in the chat, so I'll assume there are no further questions to be asked. Thank you so much for attending our webinar on malaria. What will probably happen now is this will have been recorded, and within a week or so, they'll upload it to the Mind the Bleep YouTube channel. So anyone who needs to revisit it again or go see the slides again will get a chance later on. Thank you so much.